glucose control. So why is controlling glucose level so important, and why there are so many hormones involved in glucose control? First of all, as you already know, glucose is the nutrient which is used by many tissues, and pretty much the only nutrient for the brain, because brain can use ketone and acetone bodies as the source of energy only after they are formed in sufficient amount in blood, which is about 5 to 7 days fasting. So only in this case brain switches to ketone and acetone bodies as the source of energy. Otherwise, the normal source of energy for brain, retina, germinal epithelium, and some other tissues like RBCs, for example, as well, is glucose. So it is important that glucose is not only available, but that it is kept within the normal limit of 80 to 100 milligrams per deciliter in fasting state, because hyperglycemia is dangerous, and we will see today in detail why. So these are the major reasons why blood glucose level should be kept within the limits, and why hyperglycemia is dangerous. First of all, glucose is osmotically active substance which attracts a lot of water, which increases ECF volume, so allows to expand the volume, causes increased urination, significant loss of fluid with urine, which will then lead to dehydration, volume contraction, and also long-term elevated levels of glucose damages many tissues, and that's why in diabetes mellitus we see a lot of complications, mostly neurologic complications, nephrologic complications, also vascular complications, and retina is affected, so blindness may follow. So this table presents the major hormones that are involved in glucose control. Some of them you already know, some of them you will study soon. Pay attention please that insulin is pretty much the only hormone that decreases blood glucose level. So the action of insulin is opposed to the action of other hormones, which increase blood glucose level by decreasing peripheral utilization of glucose, increasing gluconeogenesis, increasing cortisol increases gluconeogenesis and glycogen stores, plus it decreases glucose uptake by the peripheral tissue, because it shifts metabolic pathways to rather lipid and protein pathways, so the use of lipids and proteins as the source of energy, but not glucose. So cortisol is highly diabetogenic. In hypercortisolism, which is caused by either hyperplasia of adrenal cortex, or the tumor secreting cortisol, or the long-lasting treatment with corticosteroids, hypercortisolism develops. This is generally described as Cushing's syndrome, where patients have very characteristic habitus, characteristic appearance, and diabetes mellitus is very often complication of this syndrome, because corticosteroids, glucocorticoids have a high diabetogenic action. Growth hormone is also diabetogenic, and you probably already know because you learned about growth hormone, and you learned about increased secretion like acromegaly and giantism. In both conditions, diabetes mellitus type 2 is a common complication, because growth hormone is also highly diabetogenic. What does the word diabetogenic mean? Why are they diabetogenic? These hormones, growth hormones, cortisol, and also glucagon, and we will see today how glucagon secretion being increased in diabetes mellitus, because not inhibited by insulin, or by the lack of insulin rather, adds to the pathogenesis of diabetes mellitus. So all three hormones, growth hormone, cortisol, and glucagon, they can highly elevate glucose level. You remember that glucagon stimulates both gluconeogenesis and glycogenolysis. Cortisol does the same. Growth hormone mainly acts on gluconeogenesis, but it also decreases peripheral uptake of glucose by tissue. So all of these hormones have strong diabetogenic action because they increase blood glucose level and potentially they can cause diabetes. T3, T4 also increase blood glucose by all the possible ways, but because T3 and T4 act on all the metabolic pathways and in general they stimulate the metabolic rate and normally they decrease BMI, they increase metabolic rate, they increase glucose utilization, they increase heart rate and they increase oxidation in the cells, so they do not have this diabetogenic action. So in fasting state, the normal level of glucose, fasting glucose, should be more than 100, it should be milligrams per deciliter, milligrams per 100 ml, yes, that is correct, milligrams per 100 ml. During and after meal, it shouldn't be more than 140 milligrams per deciliter. Diabetes mellitus is described as the complex of polygenic metabolic disorders defined by hyperglycemia in the first place, where glucose level is above 7 millimoles per liter, which is 140, because this is 3.5 to 5.5 millimoles per liter. So it is more or equal, it is more than approximately 200. If we take in milligrams per deciliter, more than 200 milligrams per deciliter or equal to 200. It is characterized by relative or absolute, depending on the type, a relative or absolute insulin deficiency or insulin resistance, which comes with relative insulin deficiency. It is accompanied by deranged metabolism of carbohydrates, lipids, and proteins, because we already saw last lecture, and you know from biochemistry also that insulin affects all the metabolic pathways. The two major types are non-insulin dependent and insulin dependent. So non-insulin dependent is type 2, where insulin deficiency is relative, not absolute. In the previous lecture, we saw that in the table that explained the clinical role of C-peptide, that in type 2 diabetes mellitus, secretion of insulin, especially in the early stages of disease, is not decreased and may even be increased, and is often increased above the normal level. So deficiency is relative because receptors become non-sensitive. It's insulin resistance that develops in type 2, and the treatment here is not insulin, and it's not really absolute deficiency. That's why type 2 is called often non-insulin dependent diabetes mellitus. While in type 1 diabetes mellitus, the deficiency is absolute, because it is often associated with degeneration, often autoimmune degeneration of beta cells in the pancreas. So the number of cells decreases, their function decreases, and so does secretion of insulin. So there is literally not enough insulin. The condition is called insulin dependent diabetes mellitus. So here is the table that compares these two conditions. So like we already said, it absolute deficiency in type 1 and relative deficiency in type 2, where insulin secretion may be even elevated in the early stages of disease. Type 2 usually have rapid onset, and it is often called juvenile diabetes mellitus because it develops in childhood or adolescence, although nowadays it can be seen in pretty much any age, but usually it has very rapid onset, often provoked by trauma, by viral or bacterial infection, and onset is within days or weeks. While in type 2, the onset is gradual, which may last months and years, sometimes decades. Usually, because of this gradual onset, it's understandable that diabetes mellitus usually is manifested after the age of 4, and in the late ages, sometimes discovered in senior citizens, people of 70 and more, because this changes their lifestyle changes normally, weight gain, chronic overeating, decreased physical activity, which often comes with aging. Elderly people do not move around very much, so they are prone to type 2 diabetes mellitus. Body habitus is often lean in type 1 because we remember that insulin stimulates the storage of nutrients, the deposition of lipids in the adipose tissue, the deposition of glycogen, and in the lack of it, body mass is lean. It also can be protein muscle wasting because of loss of proteins, because we remember that insulin stimulates protein synthesis, and in the absence there is muscle wasting. While type 2 patients are often overweight or obese, and often this condition, especially in overweight or obese patients, is associated with metabolic syndrome. It's not just type 2, but metabolic syndrome. So ketoacidosis risk is very high in type 1 because we remember that generally insulin is protecting us from high levels of keto acids because it stimulates lipogenesis rather than lipolysis, and in the absence of insulin, lipolysis increases. The breakdown of fats releases ketonic and acetonic bodies, and the risk of ketoacidosis is very high, while in type 2 it normally does not occur unless it is really poorly controlled, absolutely not treated diabetes mellitus. Then ketoacidosis may develop, otherwise not. Treatment is very different in these two conditions because of the pathogenesis of them. So in type 2, which is caused by weight gain, decreased physical activity, diet rich in carbohydrates, chronic overeating, constant eating with small intervals between the food intake, which maintain chronically high level of insulin and develop insulin resistance. So obviously lifestyle modifications can help a lot, and decreasing weight, always recommended by at least 10% in these patients, increase in physical activity, so this normally helps. Plus the drugs that are hypoglycemic, and nowadays there are many groups of hypoglycemic drugs which are either increasing sensitivity of receptors to insulin and inhibit gluconeogenesis in the liver, like for example metformin and other biguanides. They are also drugs that help to excrete glucose with urine, those that block GLUT2 receptors in kidney. They cause glucosuria, and a significant volume of urine is excreted, but at the same time they help to decrease blood glucose level. Not the best choice, but nevertheless these drugs exist. Another group of drugs is the drugs that decrease the breakdown of saccharides in the intestines, which so they affect the enzymes, they block the enzymes. Again, not the best choice because you understand that this will cause severe diarrhea. And of course, our favorite Ozempic, which is not a new drug because it belongs to the group of drugs that are GLP-1 receptor agonists. So they stimulate the production of GLP, glucose-dependent peptides, which have incretin action. We talked about them in the first lecture in GIT. So they have all the actions of insulin. They decrease the appetite by affecting the neuropeptide in the hypothalamic appetite center. They help to normalize lipid metabolism, help to improve the weight, increase the weight loss. So they have the effects, they potentiate the effects of insulin. So, but in the treatment of type 1, it's hormonal replacement therapy because patients just lack the hormone. They cannot synthesize the hormone enough because they lack the cells. The cells are destroyed, and this is the major pathogenesis factor in pathogenesis. So that is why it's hormonal replacement therapy for the lifetime. So in the diagnosis of diabetes mellitus, we assess fasting blood glucose level, we assess urinary glucose level. Normally, as you remember, there should be no glucose in urine. All of the glucose is reabsorbed in PCT. Fasting blood glucose level should be within 80 to 100, 110 milligram per deciliter or 3.95.6 millimoles per liter. The golden standard is oral glucose tolerance test when the glucose calculated as 1 gram per the body weight is 1 gram per 1 kilo body weight is given to the patient, and then we track how quickly the glucose level drops in blood. So this is the normal body response to glucose tolerance test. In healthy people, after they ingest glucose, blood glucose level rises very quickly within the first hour to up to 140 milligrams per deciliter. But then it falls back to the normal level, and this is about normal level, 90 milligrams per deciliter within the first 2 hours. The response is not the same in patients with diabetes. The rise of glucose continues for the first 1.5 to 2 hours. You can see that during the first hour the peak is not reached, still it continues to rise, and then it falls back to the normal value during a very long period. It takes 4 to 6 hours to decrease blood glucose level to the initial. May not be necessarily normal. It is increased because they are patients with diabetes, remember, but it takes much longer to normalize blood glucose level after glucose load. So this is characteristic for patients with diabetes. So how is insulin secreted in response to hyperglycemia, and how does this curve change in diabetes mellitus type 1 and type 2? You have probably seen this in molecular biology already, right? No? So this is the normal curve of insulin secretion, and it has two phases of response: immediate response, or phase 1 here, and gradual release, or phase 2. So phase 1 is very quick. Within the first 10 minutes, you can see significant rise in plasma insulin. In response to glucose load, insulin is released, because we remember that insulin is continuously secreted and stored in the granules of beta cells. So when we give patients glucose, oral glucose load, this insulin is immediately released from the granules, because we remember that glucose stimulates beta cells, directly entering through GLUT2 receptors and causing the release of insulin and C-peptide. Later, this a very quick peak of insulin release goes down, because the stores of insulin are limited, of course, and time is required to restore the insulin stores. So the second phase is due to a gradual increase in insulin secretion and excretion from beta cells. Now on this graph, black curve stands for the normal release of insulin, while purple shows type 2 and red shows type 1. So as you can see, in type 1, the curve is absolutely flat. We don't see increase of insulin secretion in first or second phase. And this is because beta cells are destroyed. So beta cells are absent, and we know that in type 2 there is no insulin secretion at all. So neither it is stored in the granules or can be secreted on demand. The curve keeps flat, so that is why the only treatment for this type of patients is exogenous insulin for lifelong. With no medications that stimulate insulin secretion, GLP-1 receptor stimulator, or whatever else we want to use, metformin, this would not work. Also phenylurea drugs that stimulate beta cells, this would not work. Yes, please.
Why is there a drop in insulin levels that we can't have?
It's insignificant decrease. I don't know really. I have to look at it. I was looking at it myself, so I come back to it. If you happen to find out, let me know. So in type 2, as you can see, we see it here a little bit. So there is no response in the first phase. Again, because the secretion is decreased, but chronic glucose elevation still leads to increased release in glucose secretion, insulin secretion. So these are the responses, and you can see that they are different. So in type 2 diabetes patients can increase insulin level in phase 2 only, but again it is never at the same level as in healthy people, and they never have this normal initial peak of insulin release. This is the result of decreased sensitivity rather than decreased level of beta cells.
Now in type 2, there is a lot of production of insulin, because it's like the cells are resistant. So why the insulin is lower than normal people?
It's not lower because it's not absolute level. It doesn't show the absolute level. The graph doesn't show the absolute level. The graph shows the pattern of insulin excretion in response to glucose load, oral glucose load. And because insulin, as you correctly mentioned, is high, especially in the initial stages of disease, it is continuously secreted. So the storage of insulin in beta cells is limited because it is continuously secreted, and you are right, the level is high. But when stimulated, it can increase insulin level, not same as in healthy people, because again it is continuous secretion which goes independently of glucose load. That is the problem in type 2. We have a patient today, Sarah, who is a student. She was diagnosed with diabetes mellitus at age 12 and has been on basal bolus insulin regimen since that time. Over the last semester, she has had increasing difficulty maintaining glycemic control. She reports frequent polyuria, polydipsia, and fatigue. Unintentional weight loss of approximately 6 kilograms in 3 months. Several random blood glucose reading, that is fasting glucose random is showing more than 300 milligrams per deciliter, which is 3 times above the normal level. She had recently one visit to emergency department for the mild diabetic ketoacidosis. She was treated and discharged. Despite this, her glucose logs appear normal. So the logs that show how often she injects insulin appears normal, and she insists that she is following her insulin regimen. However, when reviewed, her insulin prescriptions show that she is refilling her pens far less frequently than expected for her condition and for her doses. Physical examination shows a very thin female with BMI that decreased by 2 and is now 18 kilograms per square meter of body surface, which is just on the lower border of normal and steps away from underweight. Patient, she looks thin with dry skin, looks tired. She has mild tachycardia. When injection sites are examined, there are few visible marks. Labs show very high A1C hemoglobin. Remember that for diabetes, for the diagnosis of diabetes mellitus, A1C should be 7. She has 11.7%. And for the normally controlled diabetes, it should be kept within 7.5, 8. So that is showing poorly controlled diabetes. Fasting glucose is high, serum ketones are mildly elevated, and electrolytes are mainly within normal limits with a mild hyponatremia. You remember that insulin stimulates sodium reabsorption, right? So what type, based on the patient's presentation, what type of diabetes mellitus does Sarah have?
Type 1.
Type 1, why?
She takes injections and she's like really underweight. Unintentional weight loss.
Mm-hmm. Yes. So she has all the signs and symptoms of diabetes, polyuria, polydipsia. She has high blood glucose level, but was diagnosed in the early age, 12, is on insulin injection, so that's type 1. What pattern of insulin secretion response to hyperglycemia do you expect to see?
No phase 1 or phase 2.
Mm-hmm. No phase 1, no phase 2. Why does she experience weakness? Why does she feel weak, tired all the time?
She's not able to take in the glucose.
Mm-hmm.
She's excreting all of the glucose through her body.
Yes, but still fasting glucose is 240. It's still high.
Because the protein is being used up.
Yes, very good. Because the insulin, as we remember, has protein sparing effect. So it helps to absorb amino acids, it helps to secrete proteins in the cell, works together with growth hormone. while the lack of insulin would have a proteolytic action, and she has muscle wasting. And muscle wasting means that she cannot do her daily routines without being tired. So also she may develop anemia due to the lack of amino acids and proteins, right? So a patient skips insulin injections intentionally, as it was found out later, because she is always concerned about her body image, and she thinks that she still needs to, probably not, didn't put it on the, so she still needs to lose weight, and that is why she skips insulin injections. How can skipping insulin injections would help her to lose weight?
She's using a protein.
Pathways that don't like use glucose as the main source. You would have like fat metabolism.
If there is no insulin, glucagon goes uninhibited, and glucagonoma, remember the case glucagonoma. So high glucagon level or uninhibited by insulin glucagon would do the opposite to insulin. While insulin saves the nutrients for the body, stimulating protein synthesis, stimulating lipogenesis, glucagon does the opposite. It causes the breakdown of lipids, it stimulates hormone-sensitive lipase and causes lipolysis, it causes proteolysis and muscle wasting. So in general, it helps to lose muscle mass and adipose tissue, both of them. So it's important, I have chosen this case to remind you that it is always important to assess patients with chronic diseases for depression, any signs of depression that you can see, because eating disorders may be the signs of depression or maybe the consequence of chronic depression. And pretty much every patient who has chronic condition is depressed. You have to be aware of this. You have to assess patients, watch for these signs when patients can't follow up, because if patients are depressed, they would not eat properly, they would not take medications, they would not keep to the regimen, and this would of course aggravate their condition. This would not help you to treat them. So it's very, very important to be watchful for these signs of depression. And anorexia, bulimia are just signs of them. So they may be consequences of depression, or well, this is what happens. So patient obviously has bulimia, and many patients with bulimia they are underweight. They eat, they have disturbed eating patterns, but they also use many purging techniques like what are they? Diuretics, drugs that cause diarrhea. They induce vomiting, they use self-induced vomiting. So this patient, because she has the diabetes mellitus, she just have chosen to skip insulin injections. So in case of untreated diabetes mellitus or poorly controlled, what would happen to carbohydrate metabolism? So the central in diabetes mellitus is hyperglycemia. And hyperglycemia is caused by two major factors. First of all, low insulin, because we remember that insulin is the only hormone that controls the blood glucose, that decreases blood glucose level. And secondly, it's increased glucagon, which goes unsuppressed by insulin. So a lack of insulin causes decreased glucose utilization, Increase of glucagon causes increased production of glucose through the mechanisms of gluconeogenesis and glycogenolysis. When glucose is in excess, it cannot be completely reabsorbed in the kidney. Why? Because when we are dealing with facilitated diffusion, which employs transporters, we are talking about saturation of transporters. So GLUT2 transporters are saturated, and that's why glucosuria follows. So there is glucose that appears in the urine, while normally there should be none. Glucosuria means decreased tubular reabsorption of water. Water stays where glucose stays, in the kidney tubules, because glucose is high molecular substance which attracts water, has high osmolarity. And as the result, it's polyuria or osmotic diuresis. Polyuria leads to dehydration, constriction of ECF volume, hypovolemia, low blood pressure, polydipsia, so patients are thirsty because they lose water. So water moves out of the cells, causing ECF expansion, cellular dehydration. So all of this lead to polydipsia. Finally, protein metabolism is also deranged, and decreased insulin secretion or decreased responsiveness, decreased sensitivity to insulin. So either type 1 or type 2 would anyway affect protein metabolism. It would be a high protein catabolism in the lack of insulin or insulin resistance, low amino acids uptake, so no anabolism, but protein metabolism would be shifted towards the catabolic state. Plasma amino acid concentration would be high. Muscles would be broken down, and there would be loss of muscle mass, loss of lean body mass, which would lead to weakness and asthenia. Proteins will be used as energy source, and there would be increased urinary excretion of urea in blood, and blood urea nitrogen levels may be increased. Increased gluconeogenesis, which adds to the increased blood glucose level. Lipid metabolism. Insulin activates lipoprotein lipase and inhibits hormone-sensitive lipase. In the lack of insulin, hormone-sensitive lipase, the enzyme that causes lipolysis, is activated. So that's increased hydrolysis of triglycerides with release of free fatty acids and glycerol in the blood. Again, free fatty acids they serve as the source of the substrate for gluconeogenesis, and this will increase the blood glucose level. Also, lipoprotein concentration in blood will increase. There would be dyslipidemia, and as the result, deposition of cholesterol in the arterial walls. So that's why we are talking about vascular complications and cardiovascular complications in diabetes mellitus because of deranged lipid metabolism. So when free fatty acids, so in the lack of insulin, it's pretty much the effects of glucagon, which we observe, and in the adipose tissue, you remember that the metabolism of lipids shifts towards the oxidation of fatty acids, synthesis of ketone bodies, and increased concentration of ketone bodies would lead to metabolic acidosis, ketoacidosis namely, ketonuria, and patients would have this characteristic fruity odor or acetone breath. That is in case of a diabetic ketoacidosis and coma. hyperinsulinism and hypoglycemic coma. There is often a danger of overdosing of insulin or either hypoglycemic agents that are used. Also, in case of insulinoma, insulin-secreting tumor, we can deal with hyperinsulinism and hypoglycemic coma as a result. Hypoglycemia primarily affects the brain, and drop of blood glucose level below 50-70 milligrams per deciliter would already increase the excitability of the nervous tissue, cause nervousness, trembling, sweating, hallucinations, impair motor activity. Further drop in blood level below 20 inhibits CNS, causes locomotion disturbances, decreased muscle tone, seizures, disturbances of consciousness, respiratory depression may lead to respiratory arrest, and death. So the compensatory mechanisms in hypoglycemia is stimulation of sympathoadrenal system and secretion of hyperglycemic hormones. And you remember that epi and norepi have hyperglycemic action. They increase glucose level by gluconeogenesis and glycogenolysis. Also, later in response, rise in cortisol and growth hormone secretion. And in case of hyperinsulinism, insulinoma, for example, or increased injections when patients inject themselves but they do not eat, so the treatment is intravenous 50% glucose. Any questions here? Metabolic syndrome. Metabolic syndrome describes the simultaneous occurrence of various risk factors that generally would lead to the increase of the risk of cardiovascular diseases and type 2 diabetes. So because of very common cardiovascular complications and the potential danger of stroke and death, metabolic syndrome has to be addressed early. Unfortunately, it is diagnosed very late, and it's not easy to diagnose it. Sometimes patients do not come to see the doctor unless they start having problems. Well, this condition is present and now is diagnosed in more than 30% of US population. So the condition is defined, so we are talking about metabolic syndrome when patient has at least 3 of these parameters. So what are the parameters? Abdominal obesity, which is qualified as waist circumference more than 88 centimeters in female and more than 102 centimeters in male. Arterial hypertension greater than 130/80, and dyslipidemia, which is low HDL or good cholesterol and high triglycerides or bad cholesterol. Also fasting glucose greater than 100, or if the patient already has type 2 diabetes mellitus. So the presence of any 3 of these criteria would already allow us to diagnose metabolic syndrome. It is also called syndrome X or deadly quarter because of the 4 major groups of syndromes that are found. That is abdominal obesity, number 1, hypertension, arterial hypertension, number 2, dyslipidemia, number 3, which is low HDL and high triglycerides, and high fasting glucose. So these 4 parameters, here we say 5, but actually this is 3 and 4 are known as dyslipidemia, and that's why the condition is known as deadly quarter. But for the diagnosis of metabolic syndrome, you don't need to find all 5 in patient. If you find just 3, that is already metabolic syndrome. So what causes it? What is the etiology of metabolic syndrome and what are the major manifestations? So here are the manifestations. diabetes mellitus, type 2, dyslipidemia, arterial hypertension, central adiposity, central obesity, hyperuricemia due to imbalance of protein metabolism. So the major factors that contribute to this condition and cause it is lack of exercise, genetic predisposition. In US, it's mainly citizens of Hispanic origin, Mexicans, African Americans, but mostly Mexicans are prone to this. Improper diet. So all of this lack of exercise and proper diet leads to chronic, by improper diet we mainly mean chronic overeating with short intervals between food, because you know that insulin is released normally in a little bit of excess, and when it is released in excess more than needed to utilize the glucose that you get with food, and then patients eat after another 2 hours or 3 hours, that is not enough of insulin level to drop. It stays chronically elevated because some patients are continuously eating, and this of course causes chronically elevated insulin and insulin resistance. So the consequences of insulin resistance, patients with metabolic syndrome have normally high appetite because of the lack of insulin or insulin resistance rather. The neuropeptide which is inhibiting the appetite center in the hypothalamus is not formed, or there is lack of this neuropeptide, and appetite center goes uninhibited, which makes them want to eat all the time. Hepatic glucose production is also increased, and this affects the brain. In the arteries, it's increased plaque formation due to dyslipidemia, high level of triglycerides, a low level of HDL, which serves as protective factor. In the liver, this is increased lipogenesis, because we remember that and increased glucose production in the lack of insulin, which would normally inhibit this. So in the liver, instead of glycogen production, which is driven by insulin, it's lipogenesis and increased glycogenolysis, which is happening under the low insulin or uninhibited glycogen. Decreased beta cell survival and eventually low number of beta cells. Abdominal fat due to high level of triglycerides and leads to high level of triglycerides and decreased lipolysis. There is a decrease in vasodilatation. So lack of insulin would affect the vessels. It would inhibit, it would damage the endothelium of the vessels, would decrease the secretion of nitric oxide, which is vasodilatory. And in the muscles, decrease glucose uptake and glycogen synthesis. I'm sorry for the delay. So this is the last clinical case. We are looking at metabolic syndrome. 45-year-old man presents for evaluation of progressive fatigue and shortness of breath when climbing stairs. He reports long-standing central weight gain and increasing difficulty controlling his appetite. Over the past years, he has noticed dark velvety patches of skin on the back of his neck. It's over the neck and underarms. He smokes 1 pack of cigarettes per day and has done so for more than 20 years. On examination, has a waist circumference of 112 centimeters. Remember that for the diagnosis of metabolic syndrome, patient should be on 102 or more. Blood pressure of 35/90. Patients need to have at least 130 and over 80 to be diagnosed with metabolic syndrome. And acanthosis nigricans on the neck. So acanthosis nigricans is an often finding in metabolic syndrome, and it is a hallmark of the syndrome. It is found it is found mostly on the neck, in the armpits, elbows, pressure points. In the labs, fasting labs showed elevated triglycerides, low HDL, high fasting glucose. Normally should be 110. He is concerned because his father had a heart attack at 52, and he wonders whether his smoking and weight are catching up with him. So how many internationally recognized metabolic syndrome criteria does this patient have? All of them. So what does he have?
Arterial hypertension.
Hypertension,
Abdominal obesity.
abdominal obesity,
High fasting glucose.
high fasting glucose,
Low HDL.
Yeah. High triglycerides.
high triglycerides, and low HDL. Yes. What in his history suggests high risks of cardiovascular complications?
Hypertension.
Smoking, very good. Family history, and the fact that he already experiences shortness of breath when climbing stairs. And he is only 45. Oops, sorry. So how does nicotine increase the risk of cardiovascular complications, and why smoking cessation should be recommended immediately? Vasoconstriction, because it activates sympathetic nervous system, causes sympathetic vasoconstriction, also damages endothelium, causes decrease of nitric oxide. Why can't he control his appetitis? Low insulin, right? No neuropeptide, why? Why does acanthosis nigricans develop? Is the sign of insulin resistance. High insulin levels affect keratinocytes and fibroblasts due to secretion of insulin-like growth factors, which stimulate the extra growth of keratinocytes there. What lifestyle modification does he need to make? Quit smoking, that is number one. Lose weight, number two. Increase physical activity, normalize sleep. Right, thank you very much, and sorry for the delay.